We are going to jump right into anatomy and physiology since it's down to the wire. That is, if my computer will let me. Slideshow from beginning. Evidently, it doesn't like for me to do too many clicks. So here's some terminology that you're going to need to know, not only for this lecture and for these questions, for this test. You're also going to need to know this as we go along and learn about intrapartum and postpartum. So these are some terminologies that you really want to keep in mind. Gravida just simply means a woman who is pregnant. So therefore, gravidity means pregnancy. Multigravida is when you have a woman who's been pregnant more than once. Multipara is someone who's completed more than one pregnancy. Nullagravida means never been pregnant. Nullipara, never been a parent. Para means pregnant, or para means parent. Gravida means pregnant. So how many times has she given birth? Para. How many times has she been pregnant? Parity, the number of pregnancies that reach viability. If you had somebody that had a miscarriage at 18 weeks, that is not considered para. That's considered a miscarriage. If she had been 21 weeks, then that would have been considered para. Post dates are 42 weeks and beyond. Preterm is before 37 weeks, but after 20 weeks. They cannot be considered preterm until they've reached the age of viability. Prima gravida is the patient who's been pregnant for the first time. Term is usually considered at the end of 37 weeks, so you're really looking at 37 weeks being a late preterm. It's not really considered a term baby, although it's written here this way. That actually means at the end of 37 weeks, which basically puts you at 38 weeks. We considered viability, which I already went over this some when we were talking about conception. Depending on if you watched that video yet. Is the capacity for the fetus to live outside the uterus. Usually this is after 22 to 24 weeks, but ACOG defines it as 20 weeks, so we are defining viability 20 weeks or greater. So a fetus is viable at 20 weeks, or also if it's got a weight above 500 grams. If it has a weight above 500 grams, most of your physicians think that they are past 20 weeks. Okay, gravida, GTPAL. You'll need to know this. You will have to do GTPAL. So we already talked about what gravidity is. How many times have been pregnant? So when I ask you these questions on tests, what's going to basically get you with this one is the fact that you are going to forget to include the pregnancy of the patient that comes to the office. If she comes to your office and she's pregnant, and we say your pregnant patient comes to the office, she gave birth to a set of twins, she did this, she did that, so you have to count not only the pregnancies of her, that time she's been pregnant that's been reported, you also got to include her pregnancy that she is now pregnant with. So term, how many babies were born at more than 37 weeks? How many babies reached term? Preterm, between 20 and the 37 weeks. So 20 to 37 weeks your preterm. Term is 38 to 42 weeks. Abortion is actually determined as miscarriage, but the correct medical terminology that we use is abortion. So even though they had a miscarriage, and most of your patients don't like for you to say abortion because that puts a stigma on the laws, when you're talking to your patients, you might want to say miscarriage instead of abortion. And then, of course, living means how many living children. She may have been pregnant twice, had one preterm, had one abortion, and no living children. So she could be a gravida 2, preterm 1, AB1, and living 0. Or she could have been pregnant with twins, which would have been gravida 1. Para, how many times did she give birth? She gave birth twice. But she has living 2. So actually she's been pregnant once. And even the para is considered as 1, because para doesn't mean how many babies were born at that time. It was how many times was the baby, did she give birth. So she would still be gravida 1, maybe, and the babies were born early if they were twins. So preterm 1, and then she would have living 2, and that would tell you, hey, we got twins on board. So a lot of times you will see in prenatal records when twins are born, they'll say gravida 1, para 2. That's not correct terminology. It should be gravida 1, para 1, living 2. Okay? So let's do a couple of these. Pregnant woman comes into your office. She has had 2 children at term, lost a pregnancy at 12 weeks, and had a set of twins that were born at 32 weeks. I'm giving you time to think. Okay, let's figure out her gravida. She's now pregnant. That's 1. She had 2 babies at term, so there's 2, 3. Gravida 3 so far. Lost a pregnancy. There's gravida 4. And she has a set of twins that were born at 32 weeks. So there's gravida 5, right? Pregnant, add the 2 children, add the loss, add the set of twins. So that's a gravida. Term, so she's gravida 5, she's term 2, she's preterm 1, because remember that is one birth, preterm 1, AB1, living. She's got 2 children, and she's got a set of twins, so that's 4. She'll be a gravida 5, term 2, preterm 2, or preterm 1, and AB1. And she's pregnant right now. She hasn't given birth, so she's had a loss. She's had a set of twins, so she's got living 4, AB1, term 2. Does that make sense? Okay. Next one, take a look at. Okay. This woman's not pregnant. She came to you about nutritional counseling. She has a baby at home that was born early, and she lost a pregnancy at 22 weeks. So 22 weeks is above viability. So she's not pregnant, so we don't count that her being pregnant. So she had a child and she lost a child. So that's a gravida 2. Both babies were born preterm. So she's got preterm 2. And then living, she's got 1. Awesome. So let's review the basics. Oh, the wonderful pregnancy tests. We've got all kinds of wonderful pregnancy tests out there. Some of them can actually, I was informed in the classroom today, I guess I'm really not up to date, but we have pregnancy tests that can actually tell you how many weeks pregnant you are. That's amazing. So the hormone that tells us if we're pregnant is HCG, human chorionic gonadotropin. We can actually tell as early as first day of implantation. The first day of implantation usually occurs at around 14 days post-conception. Some can be detected as early as 6 to 11 days if we do a blood. But this really, again, we're talking, this may not be as accurate because we have all these different tests that can really be done so early. So, sometimes we can determine it before, even before you have your first missed menstrual cycle. So, our HCG level is going to double every 2 days for the first 4 weeks of pregnancy. So it climbs really, really, really high. If we have a declining HCG during the time it should be rising, then we know that we're looking at a fetal loss. Or actually be embryonic loss, because that would be in the embryo stage. It rises up till about, a couple months, 60, 70 days, and then it starts declining and gets to its lowest level at about 4 months or about 130 days, when the placenta becomes the primary source of estrogen and progesterone. If we have higher than normal levels of HCG, we may be looking at abnormal gestation, such as Down syndromes, gestational trophoblastic disease, or possibly even multiple gestation. So these are some things we really want to be looking at. We also have a quantitative serum testing where we can do a blood test, and we can, it's very accurate because it does measure the HCG in the blood. So even very small, minute amounts of HCG in the blood will actually tell you. There's different types, like the sandwich type immunoassay testing. It actually uses the anti-HCG with enzymes that bond with HCG in urine. These one-step tests, they usually just pee on the applicator and it reads results. So there's a lot of, like I said, a lot of them out there that can actually even tell you up to how far pregnant you are. So here's just a little for your information. At 2 weeks, it's 50 to 500. At 3 weeks, you can see it can go from 100 to 1,000 to 10,000. And by 12 weeks, it can be anywhere by 220,000. So you really can't use your HCG levels to determine how many weeks pregnant you are. What you can do is determine that the pregnancy is progressing if you're doing serial HCGs as they increase. If they start decreasing, then you're seeing fetal loss until at that 12-week time when it's supposed to decrease. Ectopic pregnancy, we talked about these already. Decreasing may indicate that impending. The high data for Mo is the gestational trophoblastic disease, where you have those grape-like clusters. Okay, so to make an error in your pregnancy test is if we take it too early. Urine in the first part of the day is going to be more accurate than urine that you take after you've been up for several hours. False positives may result from you taking anticonvulsants or tranquilizers. You may get some false negatives from your urine being too dilute when you're taking diuretics or promethazine. Maybe you didn't collect it right. Most of the time when you used to collect your urine and take it to your doctor, you had to put it in the refrigerator. But nowadays, you just pee on the stick, and that pretty much tells them, unless you urinate at your doctor's office, and if they collect it improperly, then it could be a false negative. You can have tumors, or it could be a lab error. There's all kinds of things that could cause a pregnancy test to be either falsely positive or falsely negative. These are the ones you need to know. So let's talk about signs of pregnancy. It's very important you know the signs of pregnancy. If you learn the positive one, you'll be able to rule it out when you're trying to do this on your exam. Positive means that it's positively related to the presence of the fetus, which means we have to be able to hear those fetal heart tones, we have to see the fetus, we have to place our hands on there and feel the baby move ourselves, not just the mother telling us that the baby's moving. All these things are objective, positively attributed to the presence of the fetus. There would be no other reason why you would hear fetal heart tones. There would be no other reason other than that you see a fetus that it would not be that you are pregnant with a baby. And then if you palpate fetal movement, if you're able to tell that's fetal movement, that's positive. Some of the others you might get confused between the presumptive and the probable. And again, like I'm telling you there is a list on page 286 that you need to kind of look at. So the presumptive was presumptive. I presume I'm pregnant because I feel these changes. I miss my period. I'm tired. I have a lot of nausea and vomiting. I have very tender breasts. These are all things that are presumptive. Changes felt by the woman. Probable. These are things that an examiner would observe. Just probable. Hager sign, which is change of color in the cervix. Ballottement. Maybe he did a vaginal exam and he felt the baby move up off the cervix, and it's called ballottement. And of course, pregnancy tests. So you wouldn't really, most people think of a positive pregnancy test being a positive sign, but it's not. Pregnancy tests, as we discussed, could be falsely positive and falsely negative. So there's reasons that is only considered a probable sign. So if you'll look at your table, it will tell you all the things that would be probable signs, presumptive signs. Even movement, felt by mom, called quickening, when she first feels the baby move, is considered a presumptive sign. Because she could be gassy. So let's talk about uterine growth. First trimester of uterine growth is stimulated by the estrogen and progesterone. In that first trimester, you're going to see increased levels of vascularity and dilation of blood vessels. You're going to see hyperplasia, hypertrophy. By the time you're 7 weeks pregnant, the uterus is the size of an egg. That's not very big, is it? Of course, depending on what size eggs you buy. In 3 weeks' time, it goes from an egg to the size of an orange. By 12 weeks, it's big as a grapefruit. And by the time you're into your 12th week, the uterus is rising up out of the pelvic, so it's actually becoming an abdominal organ. So as it enlarges, like I said, about around the 12th week, the uterus is becoming an abdominal organ. So you're not going to be able to palpate it at less than 12 weeks, and you may not be able to palpate it before 14 weeks. That's why getting fetal heart tones are difficult before this age, is because you have the uterus is still in the pelvic, and it makes it a little difficult to get fetal heart tones. Lightening is another term you need to learn. It's not used until they're late in gestation, till their term, usually, hopefully. So lightening is just the dropping of the fetus about 2 weeks before labor for the nullipara. Sometimes some women who've had babies before will not experience lightening until right at the start of labor. Usually how women feel this is when the fetus drops or starts settling into the birth canal or into the pelvis. They're able to breathe better because their baby's no longer crowding their diaphragm. They're also going to start peeing more, and they may actually pee on themselves because the baby is kicking and it's a lot lower down, so there's more pressure on the bladder. Fundal height is a very good measurement that we can use to determine the growth of the fetus. We use this pretty often to see, a non-invasive way to determine if the fetus is growing accordingly. So we measure fundal height starting from the mons pubis to the top of the fundus in the uterus. Every centimeter that we can measure indicates 1 week of gestation, and usually this starts like at the belly button. Should be 20 weeks, and then from there on in, that's going to be viability, and then for each centimeter that you measure above that, it's 23 weeks. After they get to term and then the baby drops, it will go down a little bit. So you want to, pretty much, this is a very good tool in just measuring. One thing, like I said, how the fetus grows, making sure that they're, if they're 24 weeks, they're measuring 24 weeks on fundal height. But it's also good that if you're, caught at Walmart in the pickle aisle and somebody drops down and says they're fixing to have a baby, you can pretty much, if the uterus is up above the belly button, you know that they're going to be at least have a viable baby. So people who work in the paramedic field, this can be very helpful to them if they're out and the patient don't know what gestational age they are, to take a tape measure and quickly assess what they think, so they'll know what extent of resuscitation they may need to do. This Hagar sign, usually it's done and when the doctor does a pelvic exam in his office at about 6 weeks gestation. Usually you can see a softening and compressing of the lower uterine segment. Goddard's sign is the one where you're going to see the discoloration in the uterus, sort of a bluish hue. Uterus is usually anti-flexed. That's what causes a lot of urinary frequency in that first 3 months, which is unfortunately discomfort. So our uterus, of course, has to be very flexible, so it has to have a lot of contractility to it. Sometimes even after as high as the 4th month of pregnancy, which would be 16 weeks, your patient may start feeling Braxton Hicks contractions. Braxton Hicks has come and gone and come and gone. When I first started learning about OB, there was no such thing as Braxton Hicks. So now Braxton Hicks is back. And so Braxton Hicks are basically just contractions that occur that do not cause labor. And they can occur as early as 4 months pregnancy. So 16 weeks is certainly not a viable pregnancy, but you will have the contractions of the uterus. You are enlarging the uterus with the placenta, the amniotic fluid, and the baby. All this is making this placenta grow. So the uterus has to have contractions in there to kind of exercise the uterus to make it grow bigger. So you're basically going to see them. They're irregular. They can be painful, or they may not be painful. You may feel them. You may not feel them. Usually most women don't know they're even having them. And they occur usually infrequently throughout the pregnancy. Sometimes they'll bring you to your knees, and sometimes you just never even know they're there, except that you might put your hand on your belly and feel your uterus tighten, and they're not. These Braxton Hicks contractions can facilitate uterine blood flow throughout the uterus, which is going to help promote oxygen delivery to our fetus, which we're really happy to have our baby oxygenated. Sometimes if you're having quite a few of them, you'd like to go walk them off, because a lot of times they will cease with walking or exercise. They're determined Braxton Hicks versus preterm labor in that they do not cause cervical dilation. Without cervical dilation, no form of labor is occurring. So you may have a woman who says, oh, I was in labor for 3 months before my baby was born. No, she wasn't. She was having Braxton Hicks contractions, but until her uterus or her cervix started to dilate and change, she was not in labor. Although you may feel like you're in labor, because sometimes these Braxton Hicks contractions can send you to the emergency or to the OR or to the OB quite often. Our uteroplacental blood flow, of course, we've talked a little bit about placental perfusion depends on maternal blood flow to the uterus, and things that can cause a disruption is if mom has has hypertension, if she has hypotension, if she has a seizure, if she's diabetic, a lot of things that will disrupt maternal blood flow will disrupt the flow to the uterus, which in turn disrupts the flow to the placenta. Uterine blood flow increases about 20-fold, so 20 times what it was before the baby got introduced into it. Our fetal placental unit grows even more rapid than the uterine blood flow. So as that fetal placental unit is growing, we got to have a good blood flow. And as long as we have a good blood flow, we have a good, healthy fetal unit. Actually, 1/6 of our maternal blood volume, and we're going to discuss our maternal blood volume in just a little bit, but 1/6 of all of maternal blood volume is in that uterine vascular space. So you can see how when we give birth, while we even have a lot of bleeding going on because of all that vascularity in the uterus actually has its own little souffle. You can put your Doppler on the uterus and you can actually hear a whoosh, 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 and it usually matches maternal. You can also hear the Punic souffle, which is the umbilical vessels, and it matches your fetal heart rate. And it's going to sound much the same, except it's going to go whoosh, 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 because, and that's different than when you hear the heartbeat, because when you actually are hearing the heartbeat, you are going to actually hear the da 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 da. So it's going to be quick, it's going to be fast, but it's going to actually sound like a heartbeat, only smaller. Next, our good old cervical change. Without cervical change, we do not have labor. Remember that now and forever. I mentioned Gürtelsheim at 6 weeks. You have the softening of the cervical tip. You have that increased vascularity at the cervix. You have hyperplasia and hypertrophy there. That's going to cause a lot of blood to be there, presenting at the cervix. Friability, because you'll sometimes hear the physician, if a patient comes in and complains of vaginal bleeding, or if she has some bleeding after a cervical exam, the physician will tell her she has a very friable cervix. And so friability means that when you touch the cervix, it's very likely to cause bleeding. So simply because of the increased vascularity. So if you have a patient that presents with bleeding, you might want to ask them if they've had intercourse or a recent vaginal exam, because either one of those two can cause bleeding. And the blood may not come out right away. It may not come out until the next day. So always be sure and get a 24-hour past history of, did you have a vaginal exam recently, or did you have intercourse within the last 24 hours? And these are things that can cause bleeding. Sometimes vaginal bleeding, even a small amount, will cause the uterus to contract, because it just irritates the uterus. So sometimes a little bit of bleeding will make them have contractions, so they feel like they're in labor or going into labor. Pap smears, we should always do those at our very first visit, because we're having all these changes going on, all these cervical mucosa increases that we're having, and all those things are going to affect the results of a smear. So the sooner we can get that pap smear done, the better off we are. How does your cervix look before you have a baby? Well, it's nice and round, perfect shape. And then after you have a baby, it kind of looks what they call a fish mouth. It's oval. So it never goes back to the round after you have a baby. It will not go back to its shape before you had a baby. The vagina will actually stretch out, and you'll lose the rugae that causes the vaginal walls to be able to stretch and contract. Those go away and they never come back. Most things go away and don't ever go back to normal. So presence of that fetus, ballottement. A lot of times you'll hear the nurse say, well, the baby's ballottable. If you have a ballottable baby and you're at term and you think you're in labor, you're usually not, because if you have a ballottable baby, it's not applied itself in the pelvis, and it's not applied to the cervix. So it's really not really ready quite yet to be born. Now, multip can have a ballottable baby, and within an hour of going into labor, it can be signed, sealed, and delivered. But usually when you go in to do a vaginal exam and you're using your 2 fingers and you are trying to check the cervix and trying to palpate the head will bounce backward up toward the spine. Quickening, we've already mentioned quickening. When you first feel it, it's like a little flutter, maybe a little bit of gas. You just really are not aware that it's there, because the baby's not very big when you start feeling movement. Most women don't feel the baby's till around 20 weeks. It can be felt in as early as 14 weeks, which is highly unusual. One portion of your book, one chapter of your book said 16 to 20 weeks, and this portion of your book says 14 to 20 weeks. So just know that fetal movement quickening can be determined 14 weeks being the soonest that it would be palpated or be felt by the mom, to 20 weeks. 20 weeks is usually the first time, especially your nulliparas, the ones that are their first time pregnancies. So they usually feel it much later than the multiparas. Multiparas know what they're, when they feel that little flutter, they know it's the baby. So what about our vagina and our vulva? Well, we got all these hormones that are preparing the vagina that's coming up. It's going to prepare the vagina for stretching during that labor and delivery, because all of us who's had a baby definitely knows all about that stretching. We also have vaginal mucosa thickening. Our connective tissues start loosening. Thus we have the waddle. We have our smooth muscles are getting bigger and looser. Our vaginal vault's going to lengthen. And of course we're going to have that increased vascularity. Now here I told you Gödel sign was the bluish color. That is the Chadwick sign. I stand corrected. Chadwick sign is the blue sign. The Gödel sign is the softening of the cervix. And then you have the Hager sign, which is the antiflexing of the uterus. So now we've all been corrected, especially me. Okay. These signs are things that happen really early on in the pregnancy, like through the 6th to the 8th week. And this is when you're usually seeing the patients in the doctor's office, and the doctor's doing the speculum exam, and the nurse never sees these. We get a mucus plug forming at the cervix to prevent bacteria from entering into the cervix and into the uterus. So we get our little mucus plug that's formed from leukorrhea. So if it's formed from leukorrhea, when it comes out, it's going to be a white, slimy looking thing. Our secretions that we have are acidic, and because we have acidic secretions, our little pregnant women are going to be a lot more susceptible to yeast infections. So if they start having a cheesy discharge, we need to investigate further for maybe some candida yeast infections. Breasts, of course, are going to become very tender. They're going to enlarge. You may actually even see some tubercules, which are those sebaceous glands around the nipple, and they usually secrete a little waxy substance or like sebaceous earwax that's going to protect the nipple during breastfeeding. So we're all built for breastfeeding. Also, during this time with the breast, the breast actually starts secreting colostrum. It can be a white fluid, orange fluid, a bluish fluid. You may even actually see some leakage of colostrum as early as 16 weeks gestation, which is about 4 months. Kind of freaks a lot of women out to start leaking colostrum that early, and they think that's abnormal, but it's not. So you need to reassure your patients. You're also going to be able to see a lot of stria gravidarum or stretch marks, and you'll probably see you're able to see the veins in the breast a lot easier than what you were before she was pregnant. So let's go through the general body systems. The cardiovascular system, we see a lot of change in the cardiovascular system. We see things at the cardiovascular system is going to happen. What happens to the cardiovascular system is we have all this increase in blood volume. We increase our blood volume by about 50% over the normal blood volume that we would have. So if we had normally a liter of fluid circulating in our system, we would have 1.5 liters of fluid circulating in our system. This actually, this change in the system by increasing this fluid is going to protect our maternal physiological functioning. It's going to meet the metabolic demands of the pregnancy, and it's going to provide for fetal growth and development. So all these changes that occur and the increase in our vascular system meets all these functions. We're going to see some cardiac hypertrophy secondary to that increased blood volume and cardiac output because we have an increase in that to support our pregnancy. We may even hear some murmurs during pregnancy that's going to resolve after pregnancy simply because of the increased blood flow. There have been cases where cardiomyopathy has occurred after pregnancy that has gone undiagnosed, and we have seen some postpartum deaths because of it. And it's usually due because there may have been some type of cardiac congenital defect that was not diagnosed before pregnancy, and then the pregnancy caused a lot of stress on the heart, and then we developed the cardiomyopathy, which is really a bad thing. So, if you have postpartum patients that are complaining of extremities, or not extremities, but extremes of fatigue, and it's a little past what they should be feeling of postpartum things, you might want to look into that. Between that 14th and 20-week gestation, your pulse rate's going to increase by 10 to 15 beats. It's not a whole lot, but it's going to persist until birth because we have that, start having that increased fluid volume. Of course, if you're pregnant with twins, your heart rate's going to go increase significantly, especially in that 3rd trimester when you have more baby in there and less room for everything to run. Our blood pressure factors that we want to consider. Of course, if they first come in, they may be anxious, so we may take their blood pressure and it seems a little high. You want to wait a little bit before you take it a second time. You might want to wait 30 minutes to an hour and take it again before you determine they're hypertensive. It could be their position. If they're sitting upright, their blood pressure is going to be a lot higher than it is if they're lying down. And make sure that your size is correct on your blood pressure cuff. Remember, in the first trimester, up to 13 weeks, blood pressure is normal, and then it will kind of start to decrease. Sometimes this is the reason we see later on in the first trimester women that may faint at Walmart. They may look down, bend over to look at something, and as they straighten up, they may faint. This is in the latter part of the first trimester. Most of the time, blood pressure is normal. When we go talk to glucose, it's going to be different. But blood pressure is fairly normal in the first trimester. As they start into that second trimester, it will decrease up until they get about 20 weeks. By the time they get to 20 weeks, their blood pressure should start to increase. So you think about your clinical reasoning, and you've got a patient who's in their second trimester and they feel dizzy, and they've had trouble, of fainting. You might want to consider, hey, I know that in the second trimester, blood pressure decreases up to the 20 weeks. So I need to teach her how to prevent that from happening. Be sure to stand up slowly. Don't bend over to look at something and then raise up very quickly. You want to be thinking about those things. If we started seeing an increase in the second trimester before it should start, then we would be thinking, well, that's a little too soon. Maybe I need to watch her for hypertension. By the time they reach term, your blood pressure should be back to what it initially was at the beginning of the first trimester. So first trimester, normal, then decreases till up to 20 weeks in the second trimester, and then it starts to increase back up. And by the time that their term, which is 38 weeks, their blood pressure should be normal. So we start seeing something out of the normal, we want to be sure that we are documenting and recognizing that. We should not be seeing hypertension as normal anytime, and we really shouldn't be seeing hypotension except in those very few weeks between the first trimester and second trimester. One of our big bad things is supine hypotension syndrome. Anytime your patient who is pregnant lies in a supine position, all of that baby, his amniotic fluid, his placenta, all of it is lying on your vena cava. The vena cava becomes compressed. Blood flow is not flowing through like it should. When the blood flow is not flowing, the systolic blood pressure decreases. When the systolic blood pressure decreases, you have this reflex bradycardia that occurs, and women can usually faint. And we don't like for them to be in this supine hypotension. For one thing, they faint, but for another thing, if they're in this position and their vena cava is compressed, then we're not getting good blood flow to the baby. And if the baby's not getting good blood flow, the placenta's not getting good blood flow, baby's not getting good blood flow, we're not getting good oxygenation to the baby, and so our baby suffers. So we want to be sure that we don't put women in this supine position. If we have to put them in a supine position, we should always tilt their pelvic, preferably to the left, because circulation is better that way. So let's talk blood volume. What's going to mess with our cardiovascular system? Of course, blood volume. Increases 1,500 milliliter, or 40 to 50% above non-pregnant weight. So you can say my blood volume is going to increase by 50%. That's a lot. That is a whole lot. Usually starts to increase around 10th to the 12th week. And then by around 32 weeks, it's going to stop increasing. You're going to get all you're going to get. And then by around 40 weeks, it's going to start declining, because they say, it's time for the baby to get out of here. I'm not going to continue this work. It's too much work. It's too hard. So all this increased blood volume is going to cause a lot of different things. And you start thinking about it. If they have a lot of increased blood volume, one thing that's going to cause, their weight is going to be increased simply because of that. They're going to have edema probably because of that. They have increased fluid. Their cardiac output's going to increase. Respiratory is going to increase. My heart rate's probably going to increase. All these things are going to happen simply because I have all this extra fluid in here and I'm carrying it around, and it's going to make me tired. It's a very protective mechanism. It's essential for meeting the blood volume needs of that enlarging uterus. Remember, we talked about how 1/6 of your blood volume is going to go into your uterus. And of course, we want to make sure that fetal and maternal tissues are adequately perfused. And the big thing it does is it gives you a fluid reserve for compensation of blood loss during pregnancy. And blood loss during pregnancy, we see quite a bit of blood loss during pregnancy. If it wasn't for this extra fluid volume, a lot of women wouldn't survive birth because of the loss. Excuse me, I got hiccups. And even though we have this increase in our blood volume, our peripheral vasodilation is going to remain normal. And it maintains that normal blood pressure because of this vasodilation. So we're not expected to see an increase in blood pressure due to the increase in blood volume. We are just because of our peripheral vasodilation system. We will have an accelerated production of RBCs, but that doesn't mean that we are going to actually see an increase in our hematocrit, because it depends on, usually what we're going to see is a decrease simply because the plasma volume is going to increase more rapidly than what the red blood cells are going to go. So, and it actually depends on the amount of iron available. If mom's not taking in enough iron, she's not going to make very many RBCs. But hopefully she's taking in enough iron that we're going to see an increase of about 20 to 30% of red blood cells in order to support mom's needs and the baby's needs, because iron is essential in the development of tissue, tissues. Pregnancy is a time where you're going to see a lot of iron deficient moms. The physiological anemia of pregnancy is just like what I just said, just put in a little bit differently, is that plasma increases is going to exceed the RBC increases. So because of that dilution of the more plasma versus the RBCs, we're going to see a decrease in hemoglobin and hematocrit because of the hemodilution. Usually it's not noted in the first trimester because we're not developing a lot of fluids at that time. We don't start developing this till the second trimester. And that's when we mostly note it, is in the second trimester. If we see a hemoglobin less to 10 or less, or hematocrit to 35 or less, we do consider our mom anemic, and we may want to start them on iron supplements. And as y'all learned in pharmacology, iron is very gastric, causes a lot of gastric distress, and you got pregnant women who are already nauseated, have vomiting at times. It's very hard to get them to take the iron, especially their peristalsis is slowed down, so they're going to have problems with constipation. So we really need to make sure that they take their iron, and in order for them to take their iron, we order it for them to take it with meals and try to eat a lot of fiber, drink a lot of fluids. We also teach them to avoid antacids and to avoid milk, because this will decrease the absorption of iron, and we want them to increase their vitamin C intake because that increases absorption of iron. So we've clinically reasoned our way through anemia and what we can do about it and what we should do about it. White blood cell count is going to increase throughout, and it increases right at labor time. When they come in, you'll be thinking, oh my God, infection, and what you should be thinking is, oh my gosh, she's in labor, because it will increase throughout and usually peaks in that third trimester. It does not mean that they have an infection. Cardiac output. We talked a little bit about cardiac output. We have all this increased work that the body has to do. We have all this increased fluid that's going on. So our cardiac output is going to increase from about 30 to 50% by that 32nd week gestation. We have the result, of course, it results from increased stroke volume and heart rate. Because our heart rate goes up, our stroke volume goes up. And of course, it's going to occur in response to that increased tissue demand for oxygen. So why do we have an increased demand for oxygen? Well, we got a little factory going on, and we're manufacturing a baby down there, and so we're needing all the tissue perfusion we can possibly get to maintain our perfusion as well as the baby's perfusion. It is appreciably higher when the woman is in that lateral recumbent position. So we would prefer them to be either on their left side or the right side. I hope I never come in and find that you have put a patient in a supine position that is pregnant. Again, that uterus is going to block that vena cava, it's going to compress it, and our blood pressure is going to bottom out. And we definitely don't want that to happen. It's bad for mom, it's bad for baby. They have problems with it. Circulation, by the time they're 32 weeks, this decreases a little bit. Of course, we're going to start and get ready to have the baby, so the body's saying, well, we're going to be doing some bleeding here. Maybe we should watch out for start doing our blood clotting. So we start doing our clotting factors. So our tendency for blood to clot during pregnancy is simply because of those increased clotting factors. Fibrinolytic activity is usually depressed during pregnancy and postpartum, simply as a protective mechanism to decrease bleeding. But it also makes women more susceptible to thrombosis, especially after C-section. So that is why when we do a C-section, we're very careful that we put on the sequential stockings that we put on so that for the first 12 to 24 hours to help. Of course, the sooner we get them up, get them walking, the better off we are. But this will help prevent thrombosis. So this is why they are at risk for developing thrombosis, and especially after that cesarean when they have actually have a incision into their tummy and activate that process. What about our respiratory? Well, most pregnant women will tell you they can't hardly breathe at all, and I believe them. Been there, done that. So we actually have some changes in our actual body structure during pregnancy because as the uterus grows, it pushes the abdominal organs up in toward the chest cavity, and when it pushes up toward the thoracic cavity, we're going to be seeing the diaphragm getting pushed up. So there's going to be some actual structural changes happening or adaptations happening. We've already talked about our O2 requirements increasing because our metabolic rate's increasing, and we are supporting that big old tissue mass in our uterus, and even the breasts are enlarging, so we've got to support that as well. Our baby has to have oxygen. He has to have means to eliminate his carbon dioxide. So these are all things that are going to affect our respiratory rate. Because we have an elevated estrogen level because of pregnancy, our rib cage will relax, and it permits the chest expansion to occur. And therefore, as the chest expands and the diaphragm can actually be displaced by as much as 4 centimeters, it will actually move up into that chest expansion more, and it'll be a little bit shorter, but it will be able to expand. As advancing pregnancies, you will see most of your pregnant women do thoracic breathing. The diaphragm just does not descend with inspiration very well. And because it can't descend because of all that pressure from the growing uterus and it can't descend, you'll see a lot of shortness of breath going on. And some women actually panic because they're not able to breathe. And of course, that makes the situation worse. So knowing the anatomy of how pregnancy affects respiratory, you can help calm your patient down. Upper respiratory tract is more vascular because of that estrogen. You'll see a lot of nosebleeds, a lot of sinus stuffiness, and changes in the voice, and maybe some marked inflammatory responses. I'm sure that some of you have, if you've not experienced yourself, know that some pregnant women actually have a lot of nosebleeds, and it's in response to that estrogen causing all that hyperemia in the nose and edema in there. They always have this. They may have sinus headaches that are due to that sinus stuffiness, nasal congestion. And all this is all due to the estrogen, and it's a normal part of pregnancy, unfortunately. And pregnancy can also cause them to have a decrease in their hearing and earaches and sense of fullness in their ears because of all this congestion that the estrogen causes. I'm beginning to feel a little bit like that myself. So what about our renal system? Our renal system, our poor little overworked kidneys really get overworked during pregnancy. Estrogen, progesterone affects it, pressure from the enlarging uterus, and of course our increased blood volume. All four of these things can play havoc with our renal system. By the time our pregnant woman is 10 weeks pregnant, her renal pelvis and her ureters are going to dilate. So we see a lot of blocked ureters simply because, especially in the right ureter gets what they call floppy ureters. And they can actually need to have stents put in them because they become blocked. And this is a very painful procedure, and it doesn't, the stents don't cure it. They only fix it to where the urine can come out of the kidney and save the kidney. So our ureters undergo hyperplasia. They elongate, they become tortuous, and they form single or double curves. Dilated more on the right side than the left because the uterus is displaced by that sigmoid colon. Our pelvis are holding more urine. Our ureters are also holding urine. So our urine flow is slowed. If our urine flow is slowed and we're having urine stases occurring because we're not able to get it out because of those floppy ureters, we're going to be very susceptible to urinary tract infections. We've always taught our patients, please sure drink plenty of water, drink cranberry juice, get those kidneys flushed out. But if they're not able to empty their bladder and urine backs up in the pelvis, in the kidneys, and backs up in the ureters because of the pregnancy, then these women need to be taught for sure the signs and symptoms of urinary tract infection. A lot of pregnant women don't realize they have a urinary tract infection until it turns into preterm labor. So a lot of things that our patients are going to be suffering with the renal portion is they're going to have a lot of bladder irritability. Sometimes it's going to hurt to go pee. They're going to get up and pee all during the night, nocturia. And of course, and it usually happens during the early and the late part of the pregnancy. It happens early in the pregnancy because we're getting ready for getting the baby all situated and developing the fetus. And then the late pregnancy because the baby drops, like we talked about. Our glomerular filtration rate, I knew I hit that and it just didn't go. Glomerular filtration rate, that is going to increase early in pregnancy. Mainly several different reasons, but it's a good thing that it does increase is because, we need to filter out all the byproducts of what's going on. We're having an increase of hormones. We're having an increase of blood volume. The posture that women assume during pregnancy is also affecting our glomerular filtration rate. Physical activity, nutritional intake, all of these things, the glomerular filtration rate increases simply because it needs to filtrate the byproduct of all these activities. Our poor little kidneys. They have to manage that increased metabolic rate, that increased circulatory demand that we're seeing. And of course, along with all that stuff, that maternal body waste, it also now has to get rid of fetal waste. We're really overworking it. So what you say, I told you that the placenta took care of that. Well, where do you think the placenta deposits all the fetal waste? It deposits it in that membrane where maternal blood comes along, picks it up, and then the maternal blood goes through the kidneys, through the renal system, and picks up the fetal waste and has to deal with it. Our renal function is more efficient when our woman is lying in the lateral recumbent position. When we increase renal perfusion by not compressing the vena cava, we're going to increase urinary output and decrease edema. And if we increase urinary output, that's going to prevent us from having urine in the ureters and in the pelvis. We never ever give diuretics to a pregnant woman unless it is an extreme condition. And the reason we don't is because we can cause hypovolemia. And if we cause hypovolemia, get all of her fluid gone out of her body, then our placenta is not getting perfused. If our placenta is not getting perfused, our fetus is not getting oxygenated. Usually, you'll see edema in your lower extremity in the latter part of pregnancy. That's going to decrease some of our renal blood flow and glomerular filtration rate. But it's normal part of pregnancy, so we don't really need to treat edema in the lower extremities. The best thing we can do is to alleviate the symptoms is have them lie on their left side. Reabsorption of glucose in the kidneys has been impaired. Usually they'll spill some sugar out, up to 20%, so it's not unusual to see sugar spilling in a pregnant woman because the kidneys do not reabsorb the glucose. Proteinuria. We don't really like to see protein in the urine because it is abnormal. If we have 1+, that's acceptable. That could possibly be contaminants, or less than 300 milligrams per 24 hours in your 24-hour urine. Anything over that is abnormal and should be reported. Well, our skin doesn't get out of changing either. We have all those hormonal imbalances. We have these hormones coming up. It's no wonder women aren't crazy. They have all these hormonal changes early in pregnancy, and then after delivery, they have all these hormonal changes trying to get back to normal. So it's very hard emotionally on women because of these hormonal changes and imbalances. Our skin, of course, is affected by these hormonal imbalances, but it's also affected by mechanical stretching. We are going to stretch our bellies way out. We are going to stretch our breasts way out. There's a lot of things that we're going to do that is going to affect our skin. Chloasma is known as the mask of pregnancy. It's usually a brown hyperpigmentation of skin that's over the cheeks, the nose, and the forehead. It's more prone in women of dark complexion, such as Hispanics and African American. What can we do with this? Well, there's not a whole lot we can do with this, but if they stay out of the sun can cause it to darken simply because of the pigmentation of the skin. So, we tell them to avoid too much sun in order to keep it from getting worse. Nothing you put on it is going to make any difference, and usually after pregnancy this will fade away. It may take it a little while, but it will usually fade away. Line of Niger line is a line that extends from the symphysis pubis to the top of the fundus. Again, this is more notable in dark-skinned women. And this line will go away mostly, although there may be a very faint line there for a while after pregnancy. And then we have the striae gravidarum. It's basically stretch marks. And we see these mainly in the breast and around the abdomen where the connective tissue is being separated and up underneath there. So what do we do for stretch marks? Well, there's all kinds of things that a woman can actually try, such as vitamin E. but nothing really changes a whole lot. Will change these actual stretch marks. They tend to usually occur during your over the abdomen a lot. Sometimes they're really dark red, sometimes they're white. They will fade, but they never completely disappear. And we do not, as the healthcare providers, know of anything that is going to take care of getting rid of those dry. Vitamin E, of course, like I said, a lot of women use that. And there's a lot of products out there that claim to get rid of your stretch marks, but nothing has been actually proven to get rid of stretch marks. Palmar erythema. A lot of times your pregnant women will have their palms will turn red. Pruritus is a bad thing. You can actually develop PUPS, which is pruritic urticarial papules and plaques of pregnancy. It affects 1 in 130 pregnancies, and it's very significant discomfort, but it doesn't cause any adverse effects. There's nothing we can do to get rid of the pruritus. There's nothing we can do to take care of the PUPS. But usually we treat them with oral antihistamines and topical antipyretics and corticosteroid creams. If it's really severe, really severe, we may see oral steroids being given. We don't try to treat acne during pregnancy. Some women that have acne, pregnancy will clear up, and some women it will get worse. Some of the things that they usually use that are considered safe for pregnancy are topical things such as benzoyl peroxide or topical antibiotics. And they're the only ones that are considered safe. A lot of times, especially if the younger women are trying to get rid of acne, we'll be taking Accutane. Accutane should hopefully not be taken before pregnancy or during pregnancy. It's associated with a lot of fetal loss and a lot of fetal malformation. So, if you have someone young who has acne, or even hints that they may be taking Accutane or want to take Accutane, you want to be sure to tell them that no, don't be taking this. This is what it causes. Your fingernails and your hair usually will grow and look beautiful. Some women don't have that problem. Some women have an overgrowth of hair, but usually the increased blood supply usually will help the hair and the nails grow. And then in the postpartum period, all their hair falls out and they think they're going bald because they got all this excess hair. You may see that women are having increased perspiration. They feel hotter in pregnancy. And those are some of the changes that you'll see in the integumentary system. Looky there. I just didn't change the thing. So, there you go. And PUPS usually starts. I think I need another P in there. Yeah, there's supposed to be 3 P's. P-U-P-P-P. But I just put PUPS. Okay. So it usually starts on the palms of the hands and soles of the feet. And this is very irritating. First person I ever saw have this was one of our students. And she was miserable. Okay, musculoskeletal system. There's a change in everything. I don't think there's anything in your body that not affected by your pregnancy. And we're almost to the end of this chapter. Aren't y'all so thrilled? Pelvis has forward tilt. We'll have a decreased abdominal muscle tone. We're not able to tighten those muscles up. Although I did see somebody on Facebook dancing that looked like she had to be maybe 42 weeks pregnant. Her belly was way out there. And she had some moves. So, doesn't mean that you can't continue on with what you like to do in your activity. So, you have that increased weight bearing you have all your weight in front of you and your belly. that's not normally there, and so you get a realignment of your spinal curvature in late pregnancy, where you start seeing the lordosis of pregnancy. Wearing a pelvic cradle or girdle type that is made specifically for gravidative abdomens to help relieve your back pain and help keep your back in alignment are available. And a lot of women find that they're very helpful in back pain and pelvic discomfort. Relaxin, one of those ovarian hormones, is going to assist in relaxing that connective tissue of the pelvic so that you start having a relaxant in there in those connective tissues, so that when you get ready to have the baby, that there is more room for the baby to come out. That peripheral joint laxity also occurs, but we don't know why it occurs. There has been no proven thing for that. The abdomen can actually, abdominal muscles can actually separate during the third trimester. And it's really kind of discerning to the mom, because it's not a very pretty thing if they're used to their bellies being tight before pregnancy. And a lot of times this will go ahead and regain their tone, but there's sometimes it doesn't ever regain, and separation is always noticeable. Carpal tunnel in pregnancy is not unusual to see. So sometimes you're going to see patients who come in and complain about having carpal tunnel syndrome, and they'll be wearing braces. And this is caused by edema that surrounds the peripheral nerves. Usually always regresses after pregnancy, but of course, as usual, not everything always does. Not everybody fits in that category. Our syncope that we see our pregnant people having is usually during that early pregnancy, and it's related to that vasomotor instability, because we're starting to see changes in that. Postural hypotension, we talked about how it's going to start decreasing in the latter part of the pregnancy. And then you've got possible hypoglycemia, because glucose usually decreases in the maternal, in the mama during that first trimester, because the baby wants to gobble it up. Gastrointestinal. Of course, some pregnant women are starving. Some pregnant women can't eat. Some pregnant women have morning sickness that's only during that first trimester, usually starts around 4 to 6 weeks and usually ends by the first trimester, but not all women are lucky. That morning sickness, which can occur at any time during the day or night. Sometimes certain smells will trigger morning sickness. And some women are unfortunate to have morning sickness during their whole pregnancy, which is really sad. Some of the other things that are affected in the gastrointestinal system is some women start craving non-food items. And of course, this is known as pica. Some of the foods that you see people consume is related basically to culture. African American culture, they tend to eat a lot of cornstarch. Hispanics sometimes do ground up pottery. There's just whatever's in their culture that they tend to crave. And pica is related to non-food items. If you're craving chocolate, that is a food item. If you're craving strawberries, that is a food item. But even if you crave some kind of weird food combination, as long as it's has caloric value, and it's food, then that's okay. Pica, some women suffer this so badly that you almost have to say, okay, we will, you can eat so much of this, but you have to be sure that you're eating food items so that you don't decrease all your, the body's nutrition that's needed for you and for your baby to develop. So you need to question pica. A lot of women are not, really don't want to talk about that. They like to go to their laundry room and eat all their, I guess you'd keep cornstarch in your laundry room. I guess you'd keep that in your pantry. but wherever you keep your cornstarch, you probably don't eat it by the spoonfuls, whereas in pica, it's a craving. It's not a craving for what your body has a decrease of nutrients for. If it were, then we could provide that nutrient. Cornstarch has no nutrient value, so it's pica is not that. It's just an abnormal craving for non-food items. Your gums are going to bleed easily because they're spongy, and of course they have a lot more vascular uh, supply. You're going to see a decrease of those smooth muscles, so you're seeing a decrease in your peristalsis. So when your peristalsis slows down, digestion slows down. And this is all due to your increased progesterone. You're going to develop heartburn. And some ways that we can treat heartburn is to offer small meals. Don't drink when you're eating. Be sure that you remain in an upright position 30 minutes to an hour after you eat. There's certain things that you can teach them to try to help prevent heartburn. Constipation is pretty rampant in pregnant women. Again, from the increased progesterone causing water absorption from the colon, so your stool is harder. So to combat that, you would want to recommend high fiber foods, be fresh fruits, fresh vegetables, whole grains, and of course drinking plenty of fluid. And even though plenty of fluid can include milk and juices, water is the best source for them to drink to get their fluids. They drink too many juices, they can develop kidney stones or gallstones. If they drink too much milk, they'll gain too much weight, and they can also develop calcium kidney stones. So you want to be careful about what you're recommending and be very specific about things that they should and should not eat or drink. And of course, because of our slowed down peristalsis and slowed down smooth muscles, our gallbladder is going to get affected. And this is where most women develop their gallstones or start realizing they have gallbladder issues. Because our gallbladder is going to distend, we're going to have a slow emptying of the bile, and so we're going to have stones that are going to develop in the gallbladder. And you see, in the last 5 to 10 years, we see more people developing gallstones and actually having gallbladder surgery during their pregnancy. So we want to be sure that we are monitoring them for the possibility of that when they come in and complaining about pain and nausea and vomiting. So a lot of times women may suffer from fatalism, excessive salivation. And this is really irritating. We had a poor little patient that she had to carry a bottle around with her because she had such excessive salivation. So she wasn't able to eat or drink because just swallowing made her nauseated because she had to swallow so much, and then she couldn't swallow it all. So then we get to our endocrine system. Your book doesn't have a whole lot to say about your endocrine system, although it does give you a table on page 299 to look at. But most of the things that we're looking at in pregnancy with our hormones, the things that we are more concerned about, it's the progesterone. Progesterone is going to maintain your pregnancy. It maintains your pregnancy simply by relaxing your smooth muscles. A lot of women who have repeat miscarriages, a lot of the doctors will start them on progesterone supplementation, progesterone shots, to try to keep them from having miscarriage because it decreases that uterine contractility. Prolactin is your best buddy. That's produced by the anterior pituitary. That's going to assist you in... I didn't do any of that. Didn't even touch my computer. Okay. Alright, somebody's playing with my computer. There's somebody in the building. Okay, so this is going to be an increase in your early pregnancy, and it's responsible, of course, for lactation. Oxytocin helps with the letdown of lactation, but it also stimulates the uterine contractions during pregnancy. And of course, it definitely increases as the fetus matures. The oxytocin is produced by the posterior pituitary, whereas the prolactin is produced by the anterior pituitary. And then you got your human chorionic somatomammotropin, which is produced by the placenta. It's going to cause the breast enlargement, and it's also going to decrease the maternal metabolism ability going to decrease the ability of the mom to metabolize her glucose. And this is probably one of the biggest culprits in gestational diabetes, because once you deliver the placenta, it no longer produces this hormone, and so glucose goes back to normal. Then we have our thyroid, our parathyroid. Thyroxine increases, and it does not pass over the placenta. We're going to have parathyroid increases. Our maternal glucose levels are going to decrease because we're trying to meet those fetal needs. And maternal insulin does not cross the placenta. The baby, as soon as the fetus gets at a certain age, it starts producing its own insulin. So usually in early pregnancy, the pancreas is going to decrease insulin production in the maternal body so that more sugar is available to the fetus. Placental growth, corticosteroid production, all of these act together to decrease the mother's ability to use insulin. So sometimes if you have too much sugar, if you take in too much sugar, you're going to develop gestational diabetes because you're not going to have enough insulin to take care of these things. Then we're going to start with chapter 15. This is chapter 15 right here. This is your maternal and fetal nutrition. And of course, if we could get everybody to be nutritionally sound, we would all be in a better place. I'm sitting here right now finishing off my key lime cheesecake that my daughter made. That I certainly didn't need, but it was absolutely awesome. So it's really hard to monitor people's nutritional health. We all know that. Some of us are really good and some of us are really bad. So what are some things that we really want to see in maternal fetal nutrition? Again, that first trimester, especially those first 8 weeks of embryonic development, is critical because of that fetal organ development. If we take folate or folic acid before conception, and I'm sure every one of you pregnant women or non-pregnant women have probably heard about that this helps prevent neural tube defects, which is basically a failure of closure of the neural tube. And that begins usually during that first month of gestation. So about 4 weeks embryonic stage, we're starting seeing that. 0.4 milligrams is what should be taken by all potential mothers. And sometimes it's recommended that they take more depending on if they have pernicious anemia. So these are some things that we have to look at. We also have to consider overweight and underweight and how it affects our pregnancy. And both of these things are bad. And people, children that are born to overweight people tend to be overweight. And I don't know so much if it's genetic or if it's the fact that overweight people like me tend to like to eat quite a bit, and so we like to feed our children quite a bit, even though we know it's not really good for them. So we have actually seen women having babies now who have gone in and had bariatric surgery done and then have gotten pregnant after they've lost so much weight. And so we have to be sure that we are addressing those needs as well as the needs of the pregnant person. There is a box in your book that tells you about food sources of folate. Folate supplements are the easiest, fastest way to get them, but there are some things here. Liver, chicken, turkey, and goose are all really high in folate. But then the others, that's 500 micrograms. But then all the rest of them really start dropping way down. And, you kind of think, well, maybe those dark leafy green vegetables, well, they only, only 50 micrograms per serving. So when you're trying to determine the diet for someone you're trying to increase their folate, you need to, kind of look at that. Okay. Our nutritional needs are going to increase quite a bit because we have that uterine placental fetal unit that we're trying to grow. We want the uterus to grow big enough to support the fetus. We want the placenta to be nice and healthy and full of nutrients for our fetus. And of course, we want our fetus to grow well, to develop the tissue they should, to be well nourished. So we have to increase our nutrition in order for our fetus to grow correctly. Some of the things that, and other things that we had to take into consideration is that we've got increased maternal blood volume. We want to be sure that we maintain our maternal blood volume and all the constitutes, the red blood cells, the iron, everything that we need to have in there. We're going to develop our memories. We want our moms to do breastfeeding. So especially if they're going to do breastfeeding, we need our metabolic we need to be sure our nutritional needs are being met. Metabolic needs, things that we need to look at because we have a 20% increase in that metabolic rate. We need that energy to help meet those needs. Table 15.1 gives you the recommendations for daily intake of all of your iron, your zinc, your iodine, magnesium, even your water, and your calories, and it continues on over to the next page. I'm so sorry. On that table, it also tells you your what I call your ADEC, your fat soluble diets, and your vitamins, and your water soluble. So you want to make sure they don't take too many of the fat soluble diets because they will get toxic, and the water soluble diets they need to make sure they take enough of water soluble vitamins. I'm kind of fizzling out here. Okay, let's try to get through this. Weight gain during pregnancy. Of course, it significantly affects your outcome. Every one of us been pregnant, remember, dreading stepping on those scales. The doctor's either going to yell at you for gaining too much weight or not gaining enough weight. Not gaining enough weight was never my problem. So the amount that the patient should gain varies accordingly to their pre-pregnancy weight for their height. You need to know their BMI. Of course, if they're an underweight person, they should gain more weight than the normal person. If they're an overweight person, we want them to gain a little bit less. We, however, do not want to put our overweight patient on a diet, okay? Because we don't want our babies to suffer from malnutrition. So severely underweight women usually will have a preterm labor and have a low-weight baby because they can barely support their own metabolism, let alone grow a baby and maintain the pregnancy. If they don't have enough weight gain, they have what we call, and the LBWs is low birth weight. If they don't gain enough weight during their pregnancy, they are at risk for having an intrauterine growth restricted infant, an infant who just does not grow well. Usually you will see the head is quite a bit larger in proportion to the rest of the body because what nutrition that was taken in went to the most important part of the fetus, which is a developing brain, and the body kind of got left behind. If we have too much weight gain, we can see macrosomia, which means a large baby with large head. Fetal pelvic disproportion, because if we have a large baby and we have a small pelvic, then we're going to see fetal pelvic disproportion. We see a lot of operative birth. An operative birth meaning that we may have to use forceps to be able to pull the baby out. There may not be, mother's legs are really heavy and we're not able to get enough room for that baby to come out. We may have to actually use forceps to help pull the baby out. We may end up with emergency C-section, and we can also see a lot of late fetal death with someone who gained too much weight. Someone who gains 100 weight during pregnancy is just more than even her body can take. So how is that going to affect your fetus? So how much weight is too much weight? There's a table, of course, in your book that tells you what weight gain should be. Table 15.2 tells you what their pre-pregnancy weight category is, such as the underweight, normal weight, overweight, and then they've got obese, which is, the BMI is 30 or greater. So they give you how much range that should be. So basically, with your normal weight gain, a person should gain anywhere between 25 and 35 pounds. There's not a whole lot of difference between normal weight, overweight, and underweight. Underweight need to gain about 5 pounds more, so they should gain up to 40 pounds, whereas the overweight people should gain about 10 pounds less than what the normal weight gain would be for a normal person, which is 25 pounds. And then if you have the extremely obese, they don't like for them to gain more than 20 pounds. And that would encompass the fetal weight, amniotic fluid weight, the placenta weight, and the increased weight of the uterus, where mom's not putting on any extra poundage, and all of that's going into fetal development. So some of the nutrition that we are also looking at is we want to make sure that they're drinking 6 to 8 glasses of water daily, and that's around 1,500 to 2,000. Let me go back just one. Kind of odd, but I guess I didn't think anything was important between here and there. Alright, so these are some things we want to encourage them to have 6 to 8 glasses of water daily, because dehydration actually can cause them to go into preterm labor. So especially if it's in the summertime, you want them to continue with their hydration. Caffeine consumption, although there's not been any studies that actually prove that caffeine is harmful, they still want us to limit our moms to the 300 milligrams of caffeine daily. If anything over that, we say that there's an increase for miscarriage, so we continue to teach them that. And basically what this skipped is that I'm looking through your book, is it skipped protein altogether. I hope I didn't delete your, because we know that we need to have protein. Protein is extremely important for the growth of the fetus, one of the most important things, because it's needed for tissue growth. And of course our vitamin C is going to help, some zinc is going to help. So make sure that they're getting adequate protein intake. Even omega-3 fatty acid is really good. So when we start talking about omega-3, we talk about fish. And it's okay for them to eat fish as long as they're not eating large fish out of large bodies of water that has mercury in it. And there's a safety alert in there on 352 that tells you what type of fish they can eat and that it should be well done. Aspartame, which is of course your artificial sweetener, which we now have Truvia, we have Stevia, we have all kinds of sweetener that we don't have to use aspartame, but aspartame contains phenylalanine and should be avoided by moms that have PKU. And there are a lot of moms that were born with PKU that profess that they don't have it anymore. They still have can have their babies can be affected by that. Okay, so mineral requirements. We have lots of minerals. So iron is one of those mineral requirements. We talked about physiological anemia. At about 12 weeks gestation, they should be taking a supplement of 30 milligrams of iron. And I know there are a few of you who don't want to give it with meals, but pregnant women need it with meals because it's better they take it than not take it at all. Just be sure some of that meal has some vitamin C in it because it increases absorptions. Be sure they are avoiding milk and acids. So what about calcium? Calcium, and I think I missed this page when I was updating I didn't realize this had a page number. There are alternative sources for calcium. It is on page 352. And it calcium sources for women who do not drink milk. And you will notice one of the very first things in that box says fish. And it says sardines and it says salmon. Now, why would it list fish for calcium? Simply because the sardines are whole and you eat the bones, right? Salmon with the bones, processed salmon in the can has the bones in it and they're very easy to eat and they don't choke you and they're a very good source of calcium. So even if you don't like sardines, there are people that do, and I am one of them, and they are a very good choice for calcium supplementation for those women who do not like to drink milk. Greens, collard greens, turnip greens, kale, um, dried beans, refried beans, figs, orange juice, a lot of things that they can have calcium that they don't have to drink milk. Sodium is very essential. You never want to tell a pregnant woman they don't need to have salt. They have to have the sodium to maintain their electrolyte balances. They should use it in moderation. Your fat-soluble vitamins can be very toxic. Excessive A can cause congenital anomalies. So you want to be sure that you're asking if they're taking any supplemental vitamins. Their prenatal vitamins should maintain everything that they need. One thing we didn't mention was magnesium sulfate. They should have 400 milligrams a day. And their potassium we want to be sure they're taking an adequate amount of potassium because it reduces their risk for hypertension. And of course, zinc is always important in developing the nervous system in infants, so we want to be sure that we're covering those as well. Vitamin C, of course, is going to be important for that tissue formation and iron absorption. People who smoke should take more vitamin C than average because smoking interferes with the uptake of vitamin C. We talked about pica already as a craving of non-food items, clay, dirt, starch. When I was a little kid, I liked to lick the dust off the bumpers. I confess I had a fetish. But that dust just smelled so good. Again, the pica is different than food cravings. As long as it's food, it's not considered pica. Pica is non-food items. And here your book says that usually if they have this craving, they have a low hemoglobin count. It has actually been researched to where they really don't think that it has anything to do with a deficit in any of the requirements that that you would need for metabolism. So Adolescents, of course, need to have counseling with nutrition because they don't eat enough and for their own growth and development, or they don't eat the right foods, or they like to eat some of the foods that are not. So really, they just need to be counseled so we can pick out some of the foods that they do like and encourage them to what they need to eat in order for them to maintain their growth and development as well as the fetus. Lactation, if the mom determines that she wants to actually breastfeed, which is a good time to determine that you want to breastfeed, is when you're pregnant, so we can work with you. But if you are lactating, which is if you are breastfeeding, you should increase your calories by about 500. That's not a whole lot. That's a piece of cake. That's definitely not even a Big Mac. So it's not like you're going to be able to add 2 or 3 more meals because you're lactating. An increase in calories just simply means instead of having 1 serving of chicken, you might take 1.5 servings of chicken. So just keep that in mind that it's not like a free for all, can eat anything I want to because breastfeeding. Even though breastfeeding does help with weight loss, it's not going to help with weight loss if you're taking in more than you're putting out. Should always keep an adequate fluid intake, but that intake is best maintained by mom's level of thirst. I've always had an OB doctor say drink plenty of fluid so you'll drink plenty of milk. Well, actually drinking the fluid doesn't make the milk, but drinking adequate fluid intake to maintain metabolism by mom's level of thirst helps the body stay in balance so that it can make adequate milk. Most of your milk is made from calories. Try to avoid smoking, alcohol, and caffeine. And here again, you may be thinking, okay, I want to breastfeed, but I don't want to give up smoking. So should I just not do breastfeeding because I'm not going to give up smoking? Well, actually, it's better to breastfeed and smoke than not to breastfeed at all. And those are some things that we look at. Weight gain during pregnancy, again, is based on that pre-pregnant weight. And most obstetricians still recommend that 25 to 30 pounds. I'll go a little bit less for your overweight, a little bit more for your underweight. Morning sickness. How do we deal with morning sickness? And again, like I said, morning sickness can be anytime during the day or the night. So we want to address it whenever it actually occurs. The best thing for morning sickness that we can help out with morning sickness, of course it's not going to get rid of all of it, is to recommend that they eat dry starchy foods on awakening, such as dry toast or crackers. Eat small amounts frequently instead of large meals during the day. Salty or tart foods seem to decrease morning sickness, so salty fries may be the best thing you could eat for morning sickness and not eating a large meal. Don't be skipping meals and be sure you get plenty of fresh air. One thing you don't want to be is cooped up with a lot of odors that may trigger your morning sickness. Constipation is something we have to look at. So some of the things that you want to teach them about constipation, of course, is the fact that they need to eat high fiber foods and want to increase their fluids and increase their physical activity. Physical activities during pregnancy is very acceptable. Moderate exercise usually yields a lot of numerous benefits. Improves their muscle tone, helps them during labor, shortens that course of labor, and of course it promotes a sense of well-being. Of course, if they have any kind of complications, they should not be dealing with exercise. And a lot of times we see this constipation because they are taking iron tablets and because of that peristalsis. Porosis, which is heartburn. We deal with heartburn, hopefully. Heartburn is the reflux of gastric content. We can help that by, again, small meals. Don't drink liquids and don't lie down immediately after eating. Cultural influences are very important when we're trying to determine what our patients will and will not eat. Popular foods are on page 363 and 4 on popular foods with certain cultures. We want to have that open communications. See what type of variations are in their diet. Let's don't put their fetus at risk, but let's be sure that we are meeting her needs as well. She will eat certain foods that meet her certain nutritional requirements, then those are the foods we need to work with her as far as what we're going to eat. Now, some things I'd like to touch on that I didn't touch on in the PowerPoint is the fact that we need to be sure that we're doing a thorough assessment of, what they eat, what their health history is. Do they have any diabetes? Do they have any renal disease? We need to know all these things. Do they have PKU? Do they have hypertension? We've got to do a thorough assessment before we start saying these are the things you need to eat nutritional-wise. So we need to see what the usual what their diet is. What do they normally like to eat? Again, those cultural practices that we need to look at. What is their income? Are they able to afford to eat? Do we need to possibly refer them to social services or a WIC program, things like that? Look at their lactose intolerance to be sure we know what they can, other sources of calcium are. Of course, we can do body measurements and do the BMI. And that way we know exactly what weight gains. Don't forget to look at how much weight they should gain. And norms, again, are between 25 and 35. Laboratory testing. During pregnancy, the iron or the hemoglobin rate kind of goes down and then comes back up, and so usually you're starting out with the hemodilation dilution is low in the first trimester, so your hemoglobin is going to be a little higher than it is, and then it's going to be in that third and second trimester. So just be aware. We will be talking about what lab values we are going to expect, so I'm not going to really address those in this particular chapter, although this is something that Ms. Loudermilk has added. She's also included food safety, which is a very good thing to include here because a lot of women like to eat rare meat, and rare meat is really an increased risk for getting listeriosis and toxoplasmosis, along with cat scratches. So they really shouldn't be changing their own litter boxes if they have a cat. So that's another thing you should be assessing for. But it's usually not ever come under food handling and food safety. Unpasteurized milk is not a good thing for them to have. So they really need to be careful about eating any foods that are undercooked or raw, unless it's something that should be eaten raw, because they can actually develop these diseases. So we want to really make sure they know about food safety. And of course, we did talk about iron supplementation. We talked about constipation. One thing about hyperemesis gravidarum, the reason we're not talking about it here is because we talk about that more when it's in complications of pregnancy, because hyperemesis gravidarum is a complication of pregnancy, and I don't think it should be addressed in our normals that we're doing right now. So I think that pretty much covers this chapter, and we have one more chapter to do, I believe, on nursing considerations for the family, and then we will be done. with all of this. So I hope you learned something. My favorite was the fetal monitoring. How about you?